वो देखना हेलो
हेलो।
I think no one is connected. Someone reply, class is going to start or what?
लाइट बंद है तो जरा सुंदर है ना
Hello, good evening, everyone. Respected Dr. Afshan ma'am, the members of IADP, and dear doctors, we warmly welcome you all back to another episode of the Learn from the Master series organized by the International Association for Dental Practice Excellence. Crossing more than 90 webinars has truly been an incredible journey, and we sincerely thank every doctor who has attended our webinars and supported us through our Instagram, Facebook, and other platforms. Your positive feedback and encouragement inspire us to continue delivering quality educational programs. For those joining us for the very first time today, let me give you a brief introduction about IADP. The International Association for Dental Practice Excellence is an in dental education platform that believes quality education leads to predictable and successful clinical outcomes for dentists of all disciplines and skill levels. Dentistry is constantly evolving and requires continuous learning and upgrading of clinical knowledge. With this vision, we regularly conduct webinars, workshops, and academic sessions to enhance the skills of dental professionals and guide them throughout their dental journey. So, without further delay, let us begin today's episode of the Learn from the Master series. Today's topic is why RCT fails, 5 mistakes even experienced dentists make. And this insightful session will be presented by Dr. Afshan Banu. Dr. Afshan Banu is a renowned microendodontist and cosmetic dentist and the clinical director of AM Smiles Dental Clinics. She is widely known for her refined approach to endodontics, aesthetic dentistry, and laser dentistry, with a strong focus on simplified and predictable clinical protocols. Trained under Style Italiano, she seamlessly integrates global techniques into everyday dental practice. She is also an IAS 2023 Best Paper Award winner and an experienced mentor who has guided many dental professionals through advanced clinical concepts and practical applications. We are truly honored to have such an accomplished speaker with us today. And without wasting much time, I would like to invite Dr. Afshan Banu ma'am for today's discussion.
Doctor, I was like cut off a few minutes back. So can I start? Like, can I share and start, doctor?
Yes, please.
Yeah, sure. Okay. Yeah, very good morning. Sorry, a good evening to everyone present here. So, I am Dr. Afshan Banu. So, I am from Tamil Nadu, India, and I have been teaching everyone for the past 3 to 4 years. So, like, I wanted to, like, as soon as like IADP, they came and approached me, Dr. Shanuf. He asked me what topic to go about, and I told him two topics. And he himself was very much interested in this topic. Why? Because it's something which we do every day. So that's the truth. Okay. So let's not delay. Let's dive deep into root canal treatment. So we have been doing at least 1 or 2 root canal treatment every day. In spite of being so much experienced, sometimes even a small mistake can lead to failures, and the failures are not very immediate. Okay, so root canal treatments are very much predictable. Okay, so it is very much predictable. Once you get to know the anatomy of the tooth, it's very easy. You just go about doing an access cavity preparation. Once you have found out all the canals, literally it becomes a piece of cake. So once you have just enlarged the orifices of all the canals, it just becomes very easy. The next step is to just negotiate the canals, prepare it, and just obturate it. But even if I'm going to tell you that even if you're following the perfect protocols, even a little bit of mistakes here and there can lead to failures, even though we are doing RCTs every day. So what happens is that the failures do not appear immediately. Okay, they don't appear immediately. So today you're doing an RCT, the patient will not come back to you the next week itself telling, I'm having pain. Okay, so you might think that my RCT was very successful. Okay, the failure is going to happen down the line at the fourth or the fifth year. Okay, fourth or the fifth year, the patient will come back to you or go to another dentist. Okay, so most of the time the patient don't come back to the same dentist, so that's where it becomes a very silent mistake. Okay, once the RC treated teeth is actually after doing RCT, if a patient is having pain in the same teeth, patient become reluctant to come back to the same dentist. But we start to think that we have done the RCT and the patient did not have any problem, so he did not come back. But in spite of it, the patient would have walked into some other clinic, went about retreatment or extraction implants. We would not even know what happened. Okay, so that is a silent mistake. So it is not going to happen immediately. It is not going to happen within a week or within 6 months. It's going to happen ultimately in 4 or 5 years. So your failure is not a like immediate failure. So your success, a successful RCT should be something which should have a long-term success. Even after 5 years or 6 years, the RCT should be intact and the patient should not have symptoms. Okay, so according to European uh, Academy of your Endodontics, European group of endodontics, what they tell you is RCT, after doing an RCT, we are supposed to review it for up to 4 years. Okay, only if a RC treated tooth is symptomless without any lesion for more than 4 years, then it is considered as a successful treatment according to Europeans. And for American, when there is no symptom after 2 years, we consider it as a healing tooth, even if there is a lesion. Okay, so usually we follow American Academy, but Europeans consider only for 4 years if there is no symptoms at all. Only then it is considered as a successful treatment. Okay, even after 4 years. So, in fact, your failures are not immediate. You might think that you have done a perfect RCT. You might not even know that it has failed. The patient would not be coming back to you with pain. Okay, so you need to be very conscious about what are those silent mistakes which you're making in your clinical practice and which is leading to a silent failure which you never get to know at all. So I have just categorized them into 5 mistakes, which we can I have categorized into 5 steps with which you can check in each step, are you doing it or not? So let's start with inadequate case selection. So the first thing begins in your case selection, your diagnosis, and your treatment planning. Okay, so sometimes we need to be aware of what type of case we are going to work with. So the first thing which you have to keep in mind, systemic health and your prognosis of the tooth plays an important role in analyzing the treatment plan of the patient. So if a patient is with your diabetes or a cardiovascular patient, you need to decide according to it. If a patient is diabetic, the patient will not have quiet immune response, the healing capacity will be very low. So if the patient, a diabetic patient, is going to have a periapical lesion, it is going to take time to heal. You need to give time to heal instead of going for immediate obturation or a single sitting RCT. So even patients with HIV or immunocompromised conditions, those patients are not going to heal as soon as possible. Like when you compare them with a normal patient, they will not heal immediately. So you need to give them time. You need to place intracanal medicaments, and you need to treat the patient with multiple appointments. So you need to give importance to the systemic health of the patient as well, rather than just deciding by looking at the tooth. So you look at the tooth and it's just a normal small lesion present there, and we go about doing a single sitting RCT, or even we obturate within 1 week. I have seen cases where patients around 40 to 50 years come to me with diabetes. On the first day, I will be doing access cavity preparation. So what I'm talking about is which I did 7 or 8 years back. Okay. So the patient, I would have done access cavity preparation. I would have done some BMP, and the same patient, I would have given appointment after a week. the patient comes back with much more larger lesion and much more pain. Okay, so I really didn't understood like why, what happened, what I did wrong, what happened, because I have extirpated the pulp last week. The patient did not have any pain, and I just did everything correctly, the working length, everything. So where did the things go wrong? Why the patient had pain after a week? So then I realized something, that in diabetic patient, even BMP can create problems. So when you're doing biomechanical preparations, you literally push your intracanal medicaments, the debris, everything into the periapical region. In a normal patient or a normal person, it actually clears out easily. But in a diabetic patient, it takes time to clear out. Okay, so then when I started checking whether the sugar is under control, whether I started checking HbA1c, and I got to know that the sugar was not under control in the certain patient. So then I got to know after BMP. Okay, so even a little bit of debris extrusion in the apical region can cause pain in diabetic patient. So that is the importance of systemic health. So you have to keep in mind about this systemic health as well. So based on that, you need to decide the treatment planning and tooth prognosis. Sometimes we should learn to say no. That is very important. As soon as I finished my PG and came out as an endodontist, my first attitude towards clinical practice was like, I need to save every tooth. Okay, I need to save every tooth. I was like, I should save even the grade 2 mobility tooth, because as an endodontist, my job is to save the tooth. But what happened is, when I went into clinical practice, I had to become a general dentist. I was not able to be endodontist all the time. So you need to know when you need to save the tooth and when you need to let go. That's totally when you come to clinical practice, you need to start thinking in this notion: for next 10 years, which will be good for my patient, whether doing RCT or going for extraction. So you need to decide according to it. And you need to decide the tooth prognosis. So that's also very important. And then will be your attempting retreatments without proper evaluation. So whenever some RC treated, already RC treated patient comes to your clinic, we just take an X-ray. We see that it's not that much good obturated, and we just blame the other dentist and start doing re-RCT. Okay, so we never know what the other dentist went through. That's the truth. If the other dentist was not able to do the case, there definitely would be some problem. Okay, so whenever you're attempting retreatment, you have to be cautious. It might look easy, but it might be difficult. And just why the other dentist couldn't do it, you need to question yourself. You can always not tell that we are better than the other dentist. Okay, so it's not like that. Sometimes some cases are so difficult even for me. Okay, even if I go about asking my mentors who are very senior, even they tell me once in a while some cases are even difficult for them. Okay, so you never become someone who can do all the cases. So while attempting retreatments, you should keep in mind some dentist was not able to complete it, so there might be some problems. So there might be missed canals, instrument separations, or the other dentist would have broken any files. Sometimes, in X-rays, when the sealers have come around the instruments, it would look like as if it's a gutta percha. But when you look very deeply, it's an instrument. In the apical region, sometimes some dentists, they break it and leave the instrument inside. So it's like you need to check. Without a CBCT, never proceed with a retreatment. Okay, so VRF is very common in your vertical root fracture, is very common in RC treated tooth, and vertical root fractures you cannot make out in your normal RVG. It can be made out only in CBCT. So without proceeding to CBCT, without seeing CBCT, you never proceed for retreatments. And when you go for retreatments in such cases where there is VRF, you wouldn't understand. You would do everything correctly. At the end, the patient will again end up in pain. You would not know what happens, and then you will go to CBCT. So always when you're going for retreatments, go for CBCT. And then starting cases that should be referred. So this is very important. Nowadays, yeah, many people believe in specialist practice. I wouldn't say that no one should do RCT. General dentists are not supposed to do RCT. Literally, no. It's actually UG syllabus. Okay, but some of the colleges, they don't teach you that. We are supposed to do RCT after finishing BDS, but sometimes when it is a complex case, highly calcified cases, when it is more curved or inaccessible tooth, when you think that you cannot do it or it might be very risky, you don't take risk in your clinical practice, because clinical practice is somewhere where you need to worry about your reputation as well. So you should not take any risk. It's always better when you think even 40%, you think that might not be able to do this case, then you always refer that case or you call in a consultant and do it. Okay. So that is very important. And the canal morphology. So we all think that anteriors are going to be very easy, but once in a while we start getting anterior cases. Doctor, I can address the questions at the end of the session, right?
Yes.
Okay. So, like the anteriors are the most complex ones sometimes. Why? Because you don't get these cases often, but sometimes you get, like you get once in a while, you might get some case where it might have a complex anatomy like this with Toshi's type 3, or when there will be a fusioned supernumerary. So these type of cases require special equipments. That is the truth. Okay. If this case come to my clinic and if I don't have a microscope or if I don't have a bioceramic sealer, I will not be able to obturate this properly. Okay, so when you do not have a proper equipment, also you need to be very cautious, because whenever you're having anatomy like this, a different anatomy. So if I'm supposed to see a split here, so if I'm supposed to see a split here, I need to be able to see very deeply. Okay. So nowadays we are giving more importance towards loops and microscopes. So when I'm going to have a split here, or when I'm going to have a split here, I need to enlarge and I should be able to see this region, right? Only then I will be able to treat it properly. So these things are done better under magnifications, and you need to have a set up according to it. Only then it would be a better outcome for the case. So whenever you're having difficult morphology like this, you need to be cautious about it. Whether you have the equipment or not, you need to access it. I'm not telling you should always do like your RCTs. You need microscope, you need magnifications, but these type of cases, if you want to do it, do your best work, you require a magnification, these type of cases. And even these, so whenever you're having a very curved canal, okay, so even if you irrigate it properly also, you will not be able to irrigate this region. Okay, so you need to use a sonic activator or ultrasonic activator in these cases. So equipments are very important. Okay, equipments are very important in doing RCT nowadays. And also, if you can see this puff, so your bioceramic sealer is also equally important. So even if your GP is not going in that region, if bioceramic sealer is going in that region, it is considered as a successful treatment nowadays. So your bioceramic sealer and your activators, all those equipments play an important role in such difficult cases. So it's always important, you need to access your armamentarium before starting a case. What type of armamentarium you have and what type of cases you can take into your clinic. So that is also very important. And these types of apical splits as well. So these types of apical splits can be filled only with sealer. Okay, so this is GP and this part is completely filled with a sealer. So for a sealer to go inside this split, we need to activate this canal. We need to activate, we need to irrigate properly. Our BMP and irrigation protocol should be apt. Only then the sealers are going to go into this apical split. So you need to access your armamentarium, whether you have it to handle these type of cases, then go about doing that case. So that is also very important in doing case selections. And sometimes I always would like to tell all the general dentists, sometimes anteriors don't look simple. Okay, they might look simple from the front, but they might have a complex anatomy when viewed from the mesial or the distal side. So it's always important. So in these cases only, most of the you might think it's just a straight canal, I will just use a used file. And when you're going to do BMP, suddenly your file breaks out of nowhere, and you would wonder what happened. Okay, you would not know why it happened, because when you're going to take an X-ray from the front, it's going to look like a straight canal, and you would be wondering why the file broke. But it's because of this complex anatomy. Sometimes your anteriors might have a complex anatomy like this. So what you do in these cases? So what you need to do is never skip glide path and your initial canal patency for anteriors. Usually what dentists they do, they start with orifice opener and straight they go to S1, S2 or your preparation files. But what you need to not skip is your glide path in anteriors. In posteriors, people don't skip glide path, but in anteriors, they tend to skip glide path. So you need not skip glide path, so that the glide path is established properly. Then you might have it as a easy case, and the file breakage incidence will be much lesser, even in these complex anatomies. And coming to your next, access opening errors. So access opening errors, what we do right now is most of the dentists, they get confused a lot. Am I doing minimal invasive dentistry, or am I doing conservative dentistry, or am I doing operative dentistry? So you
Ma'am,
might wonder.
can I interrupt a little? Ma'am, just a question, quick question. What is the name for the glide path file?
Doctor, we usually go, you can go with GPF in Coltine, or you can go with Proglide in Dentsply, and even your Oricam has a new path, I guess. Yeah. There are many glide files in all
Dentsply
the
is
brands now.
ProGlide, right, ma'am?
Yeah. Dentsply is Proglide.
Okay, okay.
Yeah, there are glide path files in all the brands, doctor. You can go with anything.
Okay, ma'am. Thank you.
Yeah. So nowadays, what dentists they get confused is, am I in which era? Am I in operative dentistry era, or am I in conservative dentistry era, or minimal invasive dentistry era? So that is a very confusing state, because people tell us to do conservative preparations, and people also think about conservative preparations. But what I tell you is totally different. If you're going to do a conservative preparation, you need to have an armamentarium according to it. So that is my approach. So if I own 3 clinics, okay. So in one of my clinic, I don't have microscope, I don't have that much equipment. It's a very like a normal clinic. Okay. So in that clinic, I'm going to do an RCT. What I do is I don't go for conservative access cavity preparation. Okay, I go for conventional. Why? Because I don't have activator with me. I don't have microscope or loops with me. And only thing is, I should be able to visualize everything. I should be able to clean everything properly. So only then I will have a successful treatment outcome. Okay, so what I go about is I go about doing a conventional preparation. And another clinic, I have everything. I have my microscope, I have activator, everything. In that clinic, I go about doing conservative, and micro access, I don't recommend at all. Okay, so that is how you need to practice. So according to you need not depend, or you need not listen to everyone who is telling about conservative access, ultra access, truss access. Ultimately, you need to clean every nook and corners of the pulp chamber and the pulp canal. Okay. So for that, and according to the armamentarium which is available in your clinic, you choose what access cavity preparation you're going to do. Okay. So if you're someone who wants to do conservative access cavity preparation, then you need to have magnification, and you need to have an activator. Only then you will be able to do a proper BMP. You might be able to visualize everything. If you have, if you don't have these, and if you go about doing a conservative or a very small access cavity preparation, you will not be able to properly clean. So always, if you don't have anything, go for traditional. If you have, at least you have loops, you can go for conservative access. And usually, even under microscope, sometimes we don't recommend truss or ultra AC in vital tooth or in already lesion tooth and all. Why? Because the pulp chamber is not adequately cleaned. Okay, so I do not recommend it, but there are dentists who do it and who recommend it also. But I personally only like constrict my approach to traditional axis and conservative axis cavity preparation. So whenever I go for loops or microscope, I go for conservative axis cavity preparation. Whenever I don't have them, I go for traditional axis cavity preparation. So you need to have a sufficient view and sufficient space so that you can clean up everything and you can obturate everything. Okay, then next thing is your missed canals. So sometimes we might miss out, so we might think it is not there. Okay, so it's always better you search for it. You know what I do is, every time I open a lower molar, I open in such a way that I open in such a way that I expect middle mesial to be there. Okay. So there will be a canal in between two mesial canals of lower molar. The incidence is more. So middle mesial, I always do access cavity preparation in lower molars, expecting for a middle mesial. The same with the upper also. So whenever I'm going to do access cavity preparation in upper molar, I always do it in such a way that I expect 4 canals. Okay, so I expect 4 canals. I do some troughing, and I usually don't recommend troughing with burrs. So you can trough with ultrasonics. Now ultrasonics have also developed a lot. So you can trough with ultrasonics. You just need to trough from your MB1. Okay, so I think I have a case here. I will be showing you in my future slides. So you just need to trough and you need to check for it. Okay, without checking, never go about the next step. So always expect MB2, always expect your middle mesial, and you should always be thorough on your principles of access cavity preparations from your Cohen book. So you should know if there is multiple canals, how the anatomy will be. So it's always important to expect the unexpected. So you should expect for extra canals in all the cases you're doing. Only then you will be able to visualize them. And then yeah, whenever you're going to do ultra axis cavity preparations or conservative axis cavity preparations, you will have poor visibility, because of which you might go about doing a procedural error as well. Yeah, these are the depictions of how much visualization you will get when you're doing a traditional axis cavity preparation. So when you're going to do a traditional axis cavity preparation, you should be able to visualize all the orifices. When you are looking from above, you should be able to visualize all the orifices. Okay, so when you're doing a practice with naked eye, okay, without any loops, and also sometimes if you don't have activators also, you can go about doing traditional axis cavity preparation where all the orifices are visible. At the same time, it should not be very wide. Okay, it will weaken the tooth structure. It shouldn't be like this. It shouldn't be like this. It should be in straight from the pulp chamber. Your axis cavity preparation should be straight so that you can visualize all the orifices. That is the only requirement of a traditional axis cavity preparation. So when you're going to use loops or when you're going to use a microscope, you can go about doing a conservative axis cavity preparation. So conservative axis cavity preparation will be in such a way that when you're going to look from one angle, you can visualize one orifice clearly. Okay, and another angle you can visualize another orifice clearly, and another angle you can visualize another orifice clearly. But when you're going to look from the top, you won't be able to visualize all the canals, all the orifices at the time. Okay, so that is the expectation of conservative axis cavity preparation. So even conservative axis cavity preparation also with loops, I don't recommend. Only if you have sonic activators and if you have microscope, I would recommend conservative axis cavity preparation. Modify traditional and conservative a little bit. So what you can do is you can make a preparation like this. Okay, so that the cleaning over here in this region and this region and all occurs very clean. You will be able to clean very properly. So you can modify and like have a common area between conservative and a traditional access cavity preparation so that your BMP is successful. And coming to your micro access and truss, I really don't recommend it because you can leave something inside a pulp tissue which can be food to your bacterias, or you can leave any bacterias inside, and it can happen even under microscope. It might happen, so let's not take any risk with our patient. So I don't like taking risks, so I'm always someone who does only what I believe in. So I don't believe in them, so I don't really do it in my practice. So coming to, yeah, these are all how it looks, what happens. So whenever you're going to do a conservative preparation, you will not be able to remove the pulp tissue here. Okay, so it's always better to go about doing traditional access if you don't have the proper equipments with you, and go for conservative if you have a little bit of, you have ultrasonic activators or your loops with you. Yeah, so let's see one of the articles. This is not my own case, but it's from an article. So if you can see, because I don't do through the crown preparations, but sometimes I don't recommend through the crown preparations when you are not doing under microscope. Okay, so if you're someone like you have done any vital crown preparation and the patient comes back with pain and you want to do RCT now, so you think that the crown was actually given to the patient by you. So you don't want to remove the crown or break the crown because it becomes a big problem, right? So what dentists tend to do is actually go with access through the crowns. Okay, so access through the crowns in naked eye is literally, it's going to be very not at all recommended by me. Why? Because you will not be able to clearly see, and there might be more procedural errors. It's always better to remove the crown, and instead of cutting the crown into two, you can try to remove it in toto. Okay, so now if you can see here, this image is under microscope. Okay, it's under, I guess, 2.5x magnification of microscope. So now what happens is that even under this microscope, we are not able to see that there is a middle mesial canal. Okay, so even under microscope, this is how it looks under microscope. Okay, so now tell me how it looks under naked eye. So it's literally, it's not possible. Okay, so it's a middle mesial canal. So if you can see, always whenever there is going to be an extra canal, the tooth looks a little bit awkward. It looks a little bit different than normal. And usually the roots, right? Especially what I have noticed in my lower molars is that it will be very thin. Okay, it will be very thin and a shadow will be there behind. So you can expect a middle mesial in this case. So this is how it looks in under a microscope. So under your naked eye, it's literally not going to be seen. So you will miss the middle mesial here. Okay, you will think that only these two canals will be there because usually it is the possibility more probable. So you will just do BMP on the your mesiolingual and mesiobuccal, and you will do the obturation and you will finish off the case. Okay, so that's where you need to measure how well you can do the case, and you need to go about the treatment plan. So never do access cavity through the crowns under naked eye. Okay, and this is a conservative access cavity preparation. Okay, so this, when you can see, it's very small. Okay, so I can literally not be able to see the two mesial canals here, right? So it is very small. It's very conservative preparation, but at the same time, this is a conservative preparation. Okay, so this is what I do under microscope. So if you go about in high magnification, you will be able to make out 3 canal orifices. Okay, so when you don't have magnification, go for traditional access cavity preparation. Don't go for conservative. Make sure that when you're going to look from above, you can see all the canals so that you can clean it up very clearly. Now, this is about the access cavity preparation. So the third thing what every dentist and most of the dentists make is the working length inaccuracies. So whenever you're going to determine a working length, you need not depend only on radiographs, or you need not depend only on apex locator. Even after many years of practice, you need to depend on both. So you need to check the working length with apex locator, and then you need to cross check whether your apex locator is telling the truth with a radiograph. So that is how you have to practice. Only then you will have a good working length. Okay. So whenever you're going to go over obturation, so what I believe is, if you have done your instrumentation, or if you have done your BMP properly, there won't be any post-obturation pain. Okay, so if you haven't pushed your debris inside the periapical region, the patient is not going to have any post-obturation pain. So when your working length is correct, the patient should not have any post-obturation pain, according to me. So it's always better, you need to measure in both. And also, one thing what many dentists do mistakes in anteriors again is, your apical constriction can be anywhere around the apex of the tooth. Okay, it need not be here. So what they think is, they take an X-ray, they believe that from the root apex 0.5 mm short will be your working length. But in fact, your minor apical constriction can be anywhere around the tooth, in your anteriors especially. So there is a study, this is a diagram from your Cohen's book. So if you can see, minimum distance, vertical distance from the apex of to the minor apical constriction will be around 0.8 to 1 mm. Okay, so you can have your apical constriction anywhere around 0.5 to 1 mm. Okay, so sometimes your apical constriction can be 1 mm from your radiographical apex of the tooth, or it can be even at 0.5 mm. So it is always better to have a apex locator not entirely depend on radiographs. Okay, so your apical constriction can be anywhere around, or it can be anywhere shorter, that is 0.5 to 1 mm shorter from the radiographical apex. And next thing is, many dentists forget this. So this is something which is taught in UG itself. So what they forget is, in normal case, you have to keep it 1 mm short. Okay, so your working length will be 1 mm short from the radiographical apex. But when there is a lesion, your working length should be 1.5 mm shorter than the radiographical apex. And when there is root resorption from the region, okay, so if the root resorption is here, your working length should be 2 mm short from the resorption region. Okay, so this confuses many dentists. They think that so the root should be actually here. So from here 2 mm I have to separate. So from here will be my working length. No, from wherever the root is clearly visible in the RVG. Okay, some wherever the root is clearly visible, doesn't look very shady or merging with the bone. Okay, from there you have to subtract 2 mm, so that will be your working length. So whenever you have root resorption, you need to calculate according to this. Only then you will be able to have a successful RCT. So now I will be showing you one of my X-ray, so not mine. So this RCT was done by my senior in when I was doing my PG, so that's why it's a very old X-ray. So this RCT was done by my senior. Okay, after she left the college, this case came to me and I had to do RCT in this. So when I saw this X-ray, I was like very I was doubtful. Why was it like this? How did they allow in my college? How did my HOD allow this obturation? So then I went about and got to know. I took old X-rays and I compared it. So there was a root resorption. So the mistake what she did was, she kept the working length at normal. Okay, so 1 mm from the apex, if you can notice. So she did not give importance to the working length. That is, you have to subtract 2 mm if there is root resorption. So she kept it in normal and she went about doing obturation. So now what happened is that the patient had pain whenever the patient chewed something. So we had to do re-RCT in this case. After, she did this case about 3 or 4 years back. Okay, so there was pain, and so I did both together. Okay, so this is an RCT which is done by me. And this is RCT done by my senior. So this is what happens when you ignore root resorption. Okay, so when you ignore root resorption, what happens is that why do we keep it 2 mm short? Why? Because even though we kill the bacteria, the toxins will always be present here. Okay, for the toxins, that is your MMP and your some of the osteoclastic activity, that is the bone resorbing cells and the enzymes will always be present here, and their activity will always be there for the 6 months. So only after 6 months we will be able to decide where it has stopped or not. So up to 6 months still the activity will be going on, still some resorption will happen. So for that resorption to happen only we are leaving the 2 mm off. Okay, so it's always better from wherever it is visible you need to subtract 2 mm. So this is where some dentists can go wrong. And another thing is not measuring your working length once again. So this is a normal canal which is unprepared. Okay, so when you're going to measure working length in this canal, it's going to be like a rough road. Okay, so the path is going to be very long. But after doing some instrumentation, for example, if you have once got the patency of the canal or once you have used a glide path, what happens is that the canal walls become very smooth. Okay, then it becomes like a normal road, like a highway road, which is very easy to go. So your distance, so whenever you're traveling through a rough road, it takes time, right? Whenever you travel through a straight or very comfortable road, it takes very less time. The same thing applies. So when the road becomes smooth, the distance becomes small. Okay, when the road becomes smooth, the distance becomes small. So your working length changes after glide path. So your working length will change 0.5 or 1 mm after glide path. So it's always essential that you need to recheck your working length after doing glide path. So sometimes what you can do is you can go about buying a combined endomotas, like your inbuilt apex locatas in these situations, because multiple times keep on connecting the apex locatas, it would be some tedious, right? It's not like you need to only use inbuilt apex locatas, because your inbuilt apex locatas are not very accurate. You need to have a separate apex locator, but you can always use an inbuilt in between when you're doing BMP to recheck the this working length. So it's always important you recheck the working length after glide path. So it will change 0.5 to 1 mm. Okay. So other than that will be your cleaning and shaping errors. So cleaning and shaping errors, whenever you have done under preparation or like your conservative axis and you have attempted very ultra conservative axis, I don't want to cut the tooth structure at all, I want to preserve it as much as possible. If you attempt something like that, sometimes you might leave some bacteria inside, and added to it, you haven't done any irrigations, like you haven't used sodium hypo or you haven't used chlorhexidine, then it is going to add up a lot. Okay, so one of the major bacteria like E. faecalis, okay, E. faecalis is literally like a hero. Okay, no matter what you do, it keeps on coming back. It keeps on coming back even under, if you leave the E. faecalis for 4 to 5 years without any food, without any oxygen, after 5 years, somewhere a little bit of oxygen can just wake the E. faecalis back. Okay, so no matter what you do, E. faecalis keep coming back. In most of the endodontic failure cases, and many studies suggest that E. faecalis is the major bacteria which is found in endodontic failure cases. So according to many studies done, the efficacy of sodium hypo against E. faecalis, it's not that much good. Okay, so sodium hypo was effective against all other bacteria in the root canal, but E. faecalis was resistant to sodium hypo. It was quite like it worked, like chlorhexidine was stronger than sodium hypo for E. faecalis. So if you want to eradicate E. faecalis, always you need to use chlorhexidine 2.5%. I always recommend final irrigation just before obturation, chlorhexidine 2.5%. So I use ASAP RC, and never skip sodium hypo. Okay, so never skip sodium hypo. Chlorhexidine is only for E. faecalis. Okay, it is effective only against E. faecalis. It is not effective against some other bacteria and all. So your sodium hypo is going to remove the pulp tissue. and it's going to remove the bacteria. And sodium hypo is very, very important. Many dentists are afraid to use sodium hypo. Okay, so forcefully when sodium hypo is pushed periapically, only then you will have that poisoning effects and all. Okay, when your sodium hypo is just going to touch the soft tissue and wash it off, it's just going to disinfect that surface. Okay, so let's say this is one second. So let's say this is a surface. So if your sodium hypo is just touching through the surface, it will not cause any poisoning effect. It will just disinfect the surface. But when your sodium hypo is injected into it or projected into it, only then you will have that poisoning effect. Okay, so you need to use sodium hypo, use very little pressure, side vented needles according to it, or you can just deposit some sodium hypo in the pulp chamber and do BMP along with it, so that you do not extrude the sodium hypo into the apical region. And it is very important when you're doing this active solution. So what I'm telling is about active solution. So you just deposit some sodium hypo in the pulp chamber, you just do BMP. Okay, so when you're doing BMP, that sodium hypo will go inside the canal and it gets really a little bit of sodium hypo action is active throughout the BMP. So we will be doing about 15 minutes of BMP, right? So the entire 15 minutes, the sodium hypo will be in the canal. So the disinfection will be much better. Okay. And when we are going to measure the working length correctly, your sodium hypo is not extruded into the apical region. So it is very important to measure the working length correctly if you're doing active this method. Okay, so sodium hypo is very important. So you do not extrude the sodium hypo into the canals. And rubber dam, it would be better, it would be best if you are doing RCTs under rubber dam. Okay, it would be the best thing to do. But I wouldn't lie to you telling that I am doing all my cases under rubber dam. So let's be practical. I am having practices. So it's like sometimes I'm not able to put rubber dam. So in those cases, what I do is I don't obturate on the same day. So if I'm in a hurry, I don't obturate. I take some time. I give appointment on the next day and then I put rubber dam, do all the irrigations, and then I obturate. So that's how I handle. Sometimes you have rush and you are not able to finish off the case and you are not able to put rubber dam. So just don't hurry. Take your time, use all the irrigation protocols, use sodium hypo. And what regimen I follow is, while doing BMP, along with EDTA, sometimes I use sodium hypo as well. Okay. And then after doing all the biomechanical preparations, I use EDTA liquid, I activate, and then saline, and then I check GP. And if the GP is correct, I will be disinfecting my GP, and then I will be using chlorhexidine on the canal and activation. And finally, I will be doing saline and activation and dry the canals, disinfect the GP, and I will be obturating. So this is how I do. So I use sodium hypo, I use EDTA, I use Efficalis, no matter what. So whenever you are having open apex also, you can use sodium hypo. Be careful not to force sodium hypo into the canal. You can just give a little bit of sodium hypo and a little bit of activation and then wash it off immediately. So you need to use sodium hypo no matter what case it is. And coming to the syringes, what you use. So usually it is recommended for you to use 30 gauge needle for your endodontic activation. Okay. But sometimes your 30 gauge needle, when what I feel is the force that you have to give to inject that irrigant is too much. Like it's very small that it doesn't go properly. So practically I feel 30 gauge needle is very difficult to use. So you can use 26 gauge needle as well. Okay. So nothing below 26. Okay, nothing below 26. So 26 gauge needle also gives a very good disinfection when used, and it should be side vented so that your irrigant doesn't get extruded into the periapical region. And also another thing, not only your irrigant, even if there is a debris here. So even if there is a debris here, what happens is that will also get pushed inside. Okay, when you're going to use a normal syringe, when it's side vented, it will release like this. So your irrigant will actually scoop out this debris. Okay, so it will just scoop out or release the debris. But when it is in through this side, the irrigant is going to come forcefully through this way. It will actually in fact push the debris inside the periapical region. So the patient is going to have post-obturation pain. Okay, so it will take time, and in diabetic patient it might even cause a lesion. Okay, so always keep in mind, use side vented needle or minimum 26 gauge needle. 30 is going to be perfect. And other than that, how much you need to prepare. So how much taper you need to do. What should be your finishing file? 4% is fine, but in many studies, what they have suggested is that when you're going to do 4% preparation taper, your irrigants do not reach the apical region. Okay, so they do not reach the apical region. So it is always recommended that your finishing file should be 26%, 25 6%, or at least 25 4%. Never finish at 24%. Okay, never finish at 24%. Okay, 25 and 36% are almost the same. So there are many studies telling that 25 6% and 36% give almost the same debris removal when irrigants are used. Okay, so you need to finish either with 26% or 25 6% at least in some conservative or vital tooth without any lesion. Okay, there is no periapical lesion, it's a vital tooth. You are going to, like, it's a what to say, just for a bridge you're doing therapeutic RCT, like that. So in those conditions you can go about giving 25 4%. Never finish your case with 24%. In 24%, literally none of these gauge needles will go till the apex. Okay, so what I recommend is this. Okay, this cannula, Endo Flexi. It is available in Super Endo and many brands also. So you can go about buying this. This is very flexible. So if you can see, the last image is this. So if you can see, it goes till the apex. Okay, so your and it's also side vented, so you will not have any extrusion of the your debris into the apical region. Okay, so this is a image after how much debris it has removed. So this will be your 30 gauge needle, this will be your 26 gauge needle, this is your 24 gauge needle, and this is your flexi cannula. Okay, so you can use endo syringe with your flexi. This one is very good. Okay, make sure you are enlarging up to 6% in lesion cases, especially retreatment cases. It is a must. Okay, always 6% taper. Retreatment cases, lesion cases, do not keep it in 4%. You will not be able to disinfect the canal properly. Okay. One second. Yeah, another thing is your activation. So this is a sonic activator and this is an ultrasonic activator. So there is no much difference between your sonic activator and ultrasonic activator. Your sonic activator is actually your doctor friendly. It can be used easily. It is like your washing machine. Okay, whirlpool action will be there, but your ultrasonic activator will act in up and down motion. So you should not keep it deeper into the canal. You should keep it only up to the coronal or the middle third, and you need to do it only then. Otherwise, if you use ultrasonic very deeper, it might extrude your irrigant into the canal. Okay, so you need to know this. So both are same. This is a little bit easy to use. This you need some technique. Okay, you need not use it very deeper into the canal. And coming to compromised obturation, so many studies have told that whenever there is underfilled obturation, okay, so this is considered as a dead space. Okay, so whenever there is underfilled obturation, this is considered as a dead space. So this dead space is a house of bacteria. Okay, so if there is bacteria in the apical region, okay, our immunity, our inflammatory response will act on that bacteria and it will clear the bacteria. Okay, and here the bacteria will not come, but here there will be bacteria and our immune response or our blood supply will not get into this region. Okay, so because of which it becomes a hub to the bacteria. Okay, so there are studies which compare underfilled and overextended fillings. Okay, that is beyond obturation and short obturation. So there were more failures in short obturation than beyond obturation. Okay, beyond obturation sometimes did not cause any disturbance to the patient because the seal was there, and even if the beyond obturative material, it was accepted by the body sometimes. Okay, but when it is underfilled, what happened is there is bacteria here. Okay, there were no inflammatory response, nothing. So the bacteria kept on growing, and the failure was more when it is an underfilled restoration. So always never do underfilled restorations. Keep working length at the your minor constriction. Okay, and also use bioceramic sealer for a very good seal. uh, Bioceramic sealer is promoted by many people, but it doesn't always protect you from any mistakes done. Okay, so when you're going to do a short obturation like this, even if you have used bioceramic sealer, it might fail. Okay, only when everything is done correctly, your bioceramic sealer is going to be a good option, and it is going to help you. And also your sealer adaptation. So whenever there is no sealer, proper sealer, proper seal is not there, then it will be a big problem for you. Then you might have leakage, and there might be failure. And another thing is your dry canal. So when you need to check before obturation, dry the canal with the paper point. Check whether the canals are dry. Okay, if the canals are not dry, don't obturate. Okay, only if the canals are dry, then you need to obturate. If you obturate without drying, it might lead to swelling, and still there might be infections there, and it might lead to failures. And your sealer selection also. So whenever you don't have a proper system, okay, so for example, if you're going to do, you need I would not tell you need to use only bioceramic sealer, you need to use only MTA based sealer. So what I tell is, whenever you're using a sealer, you need to do according to the sealer. Okay, for example, if you're using a bioceramic sealer, it needs some amount of moisture, so you do not dry the canal. You need to dry with only one paper point. You leave a little bit of moisture inside the canal so that your bioceramic sealer can set, because its setting reaction requires water. But when you're doing an obturation with zinc oxide eugenol, you need to make sure that the canal is damn dry. Okay, only if your canal is very dry without any moisture, you're going to get a successful obturation with zinc oxide eugenol. There is nothing wrong in using zinc oxide eugenol. Okay, so zinc oxide eugenol has been used for plenty years. It has been used, and there are many RCTs done 20 years back with zinc oxide eugenol. Still, it is successful. Okay, so the only thing is you have to modify your technique according to zinc oxide eugenol. You need to dry the canal as much as possible so that you get the perfect obturation with zinc oxide eugenol. So you need to modify. Usually, I don't recommend silicone based and resin based obturative material. Why? Because they don't have that much of healing property, and also it is very difficult to remove. Your resin based and silicone based, if your previous dentist has done obturation with this, it is very difficult to remove. Even with ultrasonic also, it is very difficult to remove. Literally, the tip will break off. So always go for zinc oxide eugenol. Okay, just dry the canal. Calcium hydroxide MTA or bioceramic based is very good. And coming to your single visit RCT and your multiple visit RCT. So whenever you are going to have a case like this with lots of big lesion, it's already access cavity was done, the patient had discontinued the treatment and has come to you. So when you're looking into these cases, it is not at all a single visit RCT. Okay, so you need to disinfect the canal. Only then you will be able to have a successful treatment outcome. So even these canals, when you're going to have a diffuse lesion like this, these canals are also not a single appointment cases. So what can be a single appointment case? So whenever you're not having any lesion, like it might be a pulpitis case or acute irreversible pulpitis case, or with a mild lesion with your PDL ligament lost, so there won't be any evident lesion present. So these type of candidates are actually your single visit cases. Why? Because whenever you're going to have a big lesion like this, they require disinfection. Okay, so the bacterial load will be more. So you need extra disinfection through intracanal medicaments. Only then you will be able to give a successful treatment outcome. Okay, so this will be quality of the coronal restoration. So these are the number of cases. So this is a study done in 1995, I guess, when so this study compares the tooth which had good root filling, which had this is a good endodontics and poor endodontics, and another one will be your poor restoration and good restoration. So by the conclusion, what they have told us, even if the endo is bad, even if the root canal material is not properly obturated, when the doctor has given a very good restoration, the success rate was more. Okay, so even if the root canal was not filled properly, even if there was like short obturation was there, it was not cleaned properly, but the doctor had given a very good sealed restoration and a crown, so the root canal treatment was successful. Why? Because literally the bacteria did not get any food, so it was not able to survive. So that is also a mechanism. So whenever you have given a proper, so even if the root canal treatment is good, if your coronal restoration is not good, then your treatment will fail. So always it's very important you remove the GP 0.5 mm from the orifice, and that 0.5 mm should be filled with your entrance filling. Okay, so orifice, from the orifice. So if let's say if your orifice is here, okay, so this is a canal, so your GP should be only till here, so that you can fill your composite, your flowable composite can occupy this region, so that you'll get a very good seal. Okay, so when the coronal seal is better, your, even if your endo is not good, the success of the treatment is going to be much better. Okay, so with this, I think I will be ending my presentation and I will be addressing few questions. Yes. Ma'am, have you used endo pressure syringe or any similar device? Pressure syringe. No, doctor, I haven't used any pressure syringe. Inaccessible tooth mean posterior tooth. Inaccessible tooth means third molars, upper third molars and lower third molars, not the all the posterior tooth. When you find it difficult, okay, even sometimes I find it difficult to do RCT in third molars. So third molars are inaccessible tooth. Can this type of complex anatomy be detected in CBCT? Yes, doctor, it can be detected in CBCT, but you have to keep in mind about your FOV. Okay, so most of the CBCT centers, they will have FOV according to the implant placement, implant planning. So there is a specific specification, that is your FOV should be 4x4 for your endodontic CBCT. So only under your endodontic CBCT, all these calcifications, these extra canal anatomy can be very much good detected. Okay, so you need to ask whether your center where you're sending your CBCT, whether they have endo CBCT. So make sure about that and then send the patient. What kind of armamentarium needed for this? Doctor, whenever you're going to do a complex anatomy, my recommendation would be to have loops at least. Okay, so minimum of 3.5 to 5 magnification, or better done under microscope. And then next thing would be to go for your sonic activators, and always follow your protocol of sodium hypo, EDT, and chlorhexidine, and a bioceramic sealer, doctor. So that this would be a very good, whatever you need for a complex anatomy cases. So what is glide path? So glide path is nothing but just before we used to do with hand files, right? To get the patency of the canal. Now we have started doing it with a rotary file. So it's just glide path will be of 2 or 3 size with a taper of 3% or 3%, 4% in some cases. Very rarely you get 2%. Okay, so most of the glide path files will have 3% taper. So it will just straighten out the canal. Okay, so that your next files can go easily, glide inside and come. ProGlide from Dentsply. Yeah, ProGlide from Dentsply is your, yeah. Which loop should we buy? Okay, so doctor, loops, you need to buy Galilean or a prismatic loops, doctor. So there are many lower end loops available, so which will have plain lens. So when you're going to use a loops which is having a plain lens, your eyes will strain a lot. Okay, you need to have a concave lens, and also you need to have a prism or a you need to use a prismatic ergo loops, or you can go for a Galilean loops. Never go for plain lens loops. Okay, so you can go for TTL or a normal flip up. That is not that's not an issue. Okay, so flip up or TTL both are same. TTL will be like it is according to you. Flip up will be like this. So what matters is the type of lens used inside. So you need to go for concave, and you can go for Galilean or prismatic. Okay, then your middle mesial canal will be in your lower molars, doctor, in between your mesiobuccal and your mesiolingual. The chances of middle mesial is 3 cases out of 20. Okay, 3 out of 20 cases in India, the incidence of middle mesial is. So it's very common in India. So it is always better you look for middle mesial. So where you need to look is after you have found your middle mesiobuccal and mesiolingual in your lower molars, you just do orifice enlargement of mesiobuccal and mesiolingual. Then from your mesiobuccal to mesiolingual, you just with an endo explorer, you can just run. You will get one catch just at the center. So that will be your middle mesial. The names of ultrasonic tips. So ultrasonic tips which we use for axis cavity modifications like your troughing and all, we use ED 15D or E15D depending on what ultrasonic you have. But ultrasonic, when you're going to use, you need to have magnification. Okay, you need to have microscope or loops at least when you're going to do ultrasonic troughing. Only then you will be able to visualize it. And you can use ED 12D if you're using Satellac compatible, or you can use E12D, E15D if it is a normal EMS type ultrasonic. And you should have endo mode in it. In your ultrasonic machine, you should have endo mode. So some machines, they come for normal scaling. Okay, they won't have any modes in them. But some, they will be like G, P, and E will be mentioned, right? So E should be there because the vibrations are different for endodontic tips. And then troughing with ultrasonic. Yeah, troughing E12, E15D or ED15D. E15D is for EMS type, and ED15D is for your Satellac type. Okay. DTE type. Then no cap required for. Doctor, whenever I don't recommend access through the crown, okay? So only when I have my own patients, like last week I did a case where it was like obturation done by my junior doctor, and the patient came with a pain. So it was my own crown. So I was a little bit hesitant to remove the crown or break off. So I went about doing a selective access because I was very sure that the other two canals were obturated well, and the failure was because of missed canal. Okay. So the dentist, my junior dentist, she missed out another distal canal. There were two distal canals. So I was able to make that out in through the RVG itself. Okay. So in those cases, when I'm sure what is the mistake, okay, in those cases I can go about through access through the crown. I will just do the selective access cavity preparation and just obturate and treat that canal alone. Okay, so whenever you're going to go in through the cap, it's always better to do under microscopes. Okay, so if you're not having a microscope, it's always better to remove the crown and go about the treatment. Are crowns compulsory for premolars? Doctor, crowns are not compulsory, but restoration is compulsory. So you can go for biomimetic restorations like inlay, onlay, depending on the extent of the your cavity, or like how much the tooth structure has been lost. You need to save the sound tooth structure and restore the compromised tooth structure. So that is the principle. So you can always go for biomimetic restorations as well. And for irrigation, saline or distilled water use. Yeah, so irrigation start with sodium hypo, and during BMP you can use sodium hypo and EDTA gel. At the end of BMP you can use EDTA liquid and saline, and followed by finally before obturation chlorhexidine and saline. So this is my irrigation protocol. And in between BMP, in between files, you can use saline. Apex locator with I'm not able to get Alex locator with vital teeth. What is biomimetic restoration? So it is
Ma'am,
actually
apex locator in the vital teeth, it usually it's bleeding, right? So it
yeah.
beeps.
You are not able to,
So
you will not be able to get
yeah.
a good reading in open apex and when the pulp tissues are present. Okay. So
So
you need to
what's the
remove the pulp
option?
tissue and then only you need to check. So what you can do is you can first take radiographical apex. You can just roughly measure in the RVG and then place your hand files and check radiographical working length and remove the pulp tissue. Then you can go for apex locator. So anything can be first. First, you can check with apex locator and recheck with radiograph, or you can check with radiograph and recheck with apex locator. But you should never do it alone, like only apex locator or only radiograph. You need to always combine them both. And biomimetic restorations is inlay, onlay, overlay, doctor. Tabletop and all those restorations are actually your biomimetic restoration. No, doctor, I don't recommend metronidazole liquid at all. Mostly recommended protocol and standardized protocol right now for RCT is your sodium hypo, EDTA, and your chlorhexidine. Some people are right now telling me that even chlorhexidine is not that effective. But I don't know why to take chance. Just an extra irrigant, right? So I am keeping on using chlorhexidine, and EDTA gel during BMP and EDTA wash at the end of biomechanical preparation. Okay. Yeah, I covered till which rotary file we should prepare, I guess. So your finishing file should always be either 26% or 25.6% or at least 25.4% in vital tooth. So 25.4% is only for vital tooth. Acute irreversible pulpitis when there is no lesion at all. Okay, when there is no apical lesion. So whenever you are having apical lesion, it definitely 6%, minimum 20 in posteriors, molars, 25 can be in premolars and canine, and 30 in anteriors, it depending on the size of the canal. But 6% taper is compulsory in lesion cases. What about guided endodontics? Doctor, I don't know much about guided endodontics because I haven't done it,
Ma'am,
anything like that. Okay.
ma'am, so what about
Yes.
IDS? When we should do IDS after opening the
Immediate
glide
dentin
path
sealing,
after or
doctor. You're
before?
talking about immediate dentin
Yes,
sealing.
yes, ma'am.
Okay. Yeah, tell me, doctor. Please complete your question.
Ma'am, when we should do this? After opening the orifice? Just after opening the orifice or after glide path or after all BMP procedure?
Immediate dentin sealing, we don't do it on endo at all, doctor. As far as I know. Immediate
Ma'am,
dentin
but
sealing, we do it on vital tooth. Okay. So on vital tooth, when we are doing veneer preparations, we do immediate dentin sealing so that there is no irritation or the bonding of the restoration will be much better. Okay. So that's why we do immediate dentin sealing. I haven't heard about endo immediate dentin sealing.
What about the first irrigant after opening the access cavity? What should be the first irrigant to
First
open the
irrigant
canal
always
and
sodium hypo, doctor. In vital tooth, if it is bleeding because of pulp tissue, my first irrigant will be sodium hypo. But if I'm not sure whether I have perforated and the bleeding is because of perforation or because of pulp tissue, then I will not start with sodium hypo. First, I will clear out. I will stop the bleeding with any hemostatic liquid, or I will repeated saline irrigation. I will do. I will make sure that the bleeding is because of pulp tissue. Once I have made sure the bleeding is because of pulp tissue, I will go use sodium hypo, activation, remove the pulp tissue, automatically the bleeding will stop. Okay. And then we can go about measuring the working length, PMP, everything. So you just need to extirpate the pulp first. As soon as you do access cavity preparation, you need to enlarge your orifices, remove the pulp tissue. So your sodium hypo is also used for removal of pulp tissue. So your sodium hypo will actually dissolute the pulp tissue. And when you're extirpating the pulp, after extirpation, literally there won't be any bleeding. So then you can measure your working length and then you can start doing BMP. And during BMP, like how I said, you can use EDTA gel and you can use sodium hypo as a working solution. And at the end, you can obturate, just before obturation, you can use chlorhexidine.
And can we use
Hi,
EDTA with hypochlorite?
No,
EDTA
you can
for
use,
hypochlorite.
doctor. You can use, no reaction will happen when used together. But sodium hypo and
Which conditions?
chlorhexidine. Yes,
Yes,
doctor?
yes, yes.
Yeah, sodium hypo and
Then,
chlorhexidine, when combined together, they will become reddish in color. Okay. So,
carcinogenic.
yeah, no, not anything harmful. It just forms precipitates. Okay, so it will stick inside the root canal, right? So that's why. Other than
Then,
that, there
in which
won't.
condition we can use this? In which condition hypo and the EDT can be used? In all
In all the
cases,
conditions,
all
doctor, no,
situations.
no, not an issue at all. You can use, like you can just, what I do is I will just inject a little bit of sodium hypo in the pulp chamber, apply EDTA gel over my file, rotary files, and I will just do BMP. Okay.
Okay.
Nothing
But the
will happen.
first
Okay.
irritant is like this.
Yes,
Okay.
doctor.
Okay. Then first when you opening the oasis cavity, then you do all this
No. As soon as
chambers
I open my
filled with.
access cavity preparation, I will just do orifice enlargement. Okay. First, as soon as I open my access cavity preparation, my first step will be orifice enlargement to locate the canal and to do orifice enlargement. And then to extirpate the pulp. Okay. So to extirpate the pulp, sometimes I might require some sodium hypo. So I will just inject a little bit of sodium hypo in the pulp chamber and I will activate so that the pulp tissue gets dissolved. And then I will be using my broach or reamers to remove the pulp tissue first, if it's a vital tooth. Okay. So after removing the pulp tissue, I will be checking my working length and then I will be going to do my rotary endo. And while doing my rotary, I will again be putting some sodium hypo in the pulp chamber and using EDTA gel over my files, and I will be doing my rotary, all the 3 files or 4 files, whatever I'm going to use. After doing BMP, I will give a EDTA wash with a EDTA liquid, then again saline wash, and then I will check my GP. If it is correct, then I will disinfect my GP with hypo, and then I will disinfect the canal with chlorhexidine, saline, dry the canal, and I will obturate. So this is how I do BMP. Okay. Is this clear, doctor?
Okay.
Any doubts?
Yes, ma'am. Thank you.
Ma'am,
Yes,
do you dilute sodium hypochlorite?
No, doctor, I don't dilute. I use 3
What
to
is the
5% sodium hypo.
Okay.
3 to
And ma'am,
5%.
3 to
So if
5%
I'm,
the sodium hypo, how much ml do you irrigate? Like how
doctor, very little, only 0.5 ml. Okay, very
Oh,
little.
okay. Okay,
Only
okay.
0.5 ml into the pulp chamber. I will not inject into the canal, deep into the canal, only in the pulp chamber, activation with the sonic or ultrasonic, and then I will just wash it off. Okay.
Hi, doctor.
And
I
ma'am,
have a
once
small.
you have
Hi,
used,
doctor.
ma'am, once you have used the rotary files, after that you don't use plain hypo, right?
No. I don't use hypo. Only during my
Uh-huh.
BMP and on the initial steps, I will be using hypo.
Okay, ma'am. Okay.
Hi, doctor. I have a doubt, doctor. Hello.
Yes, doctor. Yeah.
Doctor, my doubt is like if it is the open apex and if we are not doing any apexification procedure and directly going with obturation, is it the same rule we follow as what you told
No,
in
doctor.
resort?
Never open apex, never go with normal obturation. Okay. So open apex, you have to always place a plug. Nowadays, it is very easy to place a plug because you have bioceramic putty available, right? So syringe type. So it's directly injectable into the canal. You can just place 2 or 3 mm. How much ever thickness, it doesn't matter. There is no specific protocol telling only this much should be your plug or only 2 mm should be your plug. Okay. So it can be of any thickness. You just inject the putty, you just compress it with your plugger, and on top of it, you just obturate. Okay, so without plug, if you obturate, what happens is that sometimes your GP might dislodge and go beyond, and there won't be apical seal apical seal will not be there. So there will be chances of more failures. Okay, is this clear, doctor?
Yes,
In
doctor. So, open apex, how much short we should keep? Is it just at the apex where
doctor, how you do is after doing like if it is an open apex case, and you're going to do apexification. So always we need to do apexification. So what we do is we will just working length you can keep 2 mm shorter. Okay, do all the BMP
Okay.
and everything. And finally,
Okay.
before obturation, you just keep bioceramic putty, you inject into the canal. You
Okay.
compress into the canal with the plugger. Okay, you need to have various sizes of pluggers for a tooth,
Okay.
because some very 8 size or something only goes inside molars. So you need to have a plugger and just compress them into the canal, and then you can keep a GP which is tightly fitting, and you can obturate normally.
Okay. Okay. Okay, doctor. Thank you. That's clear.
Yeah.
Thank you so much.
So calcium hydroxide powder, doctor. So whenever doctor Techno, yeah, LG7. So whenever you're going to keep a intracanal medicament, you should never use ready-made paste which is available. Okay. So what is the difference between normal calcium hydroxide paste and with iodoform paste? So your normal calcium hydroxide paste will have less substantivity. Okay, so let's say a patient from some other country has come to my clinic and he has a very big lesion. I cannot obturate. I tell him I cannot obturate. I'm going to keep medication. He tells me I will go and I will come back after 3 months. Okay, in that situation, I will be keeping calcium hydroxide with iodoform, that is Metapex. Why? Because there will be slow release and the substantivity of the material is good. So you can keep the material inside the tooth for 3 months. And after 3 months, when the patient comes back, I can remove it off and go about the normal treatment. Okay. So immediately, if you're going to obturate just in 1 week or 2 weeks, then you can always go for calcium hydroxide powder liquid format, readily mix it, place it into the canal using lentulospiral. Okay, dispense it into the canal using lentulospiral, and you need to leave at least after 5 days only the calcium hydroxide will start to release. So you need to leave minimum 1 week. And after 1 week, if the canal is dry, you can go for obturation. So this is how your intracanal medicament can be. And TAP, yeah, TAP is a triple antibiotic paste, which also I follow that. Your metronidazole, minocycline, and your ciprofloxacin. So all these three freshly mixed. So you take one tablet of each, you just put it on your amalgam mortar pestle, right? You put it on that mortar and you just make it into a powder. You mix it with polyethylene glycol, which is just a carrier, and you make it into a paste and you keep it inside the patient's canal. So now when you use TAPs, whenever there is weeping canal and whenever there is endoperio lesion, whenever there is like sinus tract opening, so those type of very heavy cases, I use TAP. So after using TAP, you have to leave the TAP for 3 weeks inside the canal. After 3 weeks, if the canal is dry, you can go for obturation. So this is how you can follow. But most of the cases require only calcium hydroxide. Okay, so TAP cases are like very, you will get to know, it will be very too much of lesion will be there. So in those cases, you can go for TAP. Twin clean, yeah, always. You can use twin clean. I don't use, but many of my colleagues, they use twin clean as a final irrigant, right? You have to mix, it's also a sodium hypo, right? So you need to mix it with sodium hypo and you need to use. Yeah, it is also recommended, but I don't use it in my practice. Why there is pain
Ma'am,
after BMP? Yeah, doctor.
ma'am, can we use Metapex instead of bioceramic putty and then obturate? Because if we don't have.
No, doctor. Why? Because actually, when you're placing Metapex as intracanal medicament, you have to be very careful that it doesn't go beyond. Okay. If it goes beyond, it will irritate, and also it doesn't resorb. Okay, it doesn't have any healing action, that much of healing action. Why? Because your Metapex will have lots of bismuth in them. Okay, that is your radio opaque opacifiers. So now the problem is, when you're going to do apexification, it might go beyond, right? Because it's open. So your MTA putty or bioceramic putty will be a best option here. Why? Because even if it goes beyond, the patient is not going to have any problem. Okay, so you need not use Metapex in that situation. So always better to go for bioceramic putty or MTA putty. MTA putty is available in all the situation, all the brands now. Even in Mark also it is available. Why there is
Ma'am,
spill?
that
Yes,
ma'am,
doctor.
that carrier you shared that mixed with a triple antibiotic was glycerin actually, glycerin we can use.
Polyethylene glycol.
It is a type of glycerin,
It is
glycol
not a
is.
type of glycerin, but it is a carrier. But it's recommended to use polyethylene glycol only. Okay.
Okay, something is different. Kuch
Yeah, something is different.
different solvent.
Yeah, it's a
Okay,
different
okay,
carrier,
ma'am.
not glycerin. So where was
Ma'am,
I?
we can use with saline water also. This triple antibiotic, saline
Yes,
water.
no, doctor, but the substantivity will be very less. Okay. Saline, what happens is it gets absorbed. Okay. So you will not have
Distill
very slow release. You might
water.
have to repeat the intracanal medicament often. Like you cannot leave it there for 3 weeks.
Ma'am,
Did you get?
Okay.
do you
Yeah.
recommend leather mix as a intracanal medicament? Leather mix, which has corticosteroid, I believe,
No, doctor. No, I don't recommend that.
because it works wonders. Like whenever
Yeah,
patient comes back with,
corticosteroids works in every aspects of life, doctor. Okay, so corticosteroids will seem like it's curing you, but in fact, it will actually what it does is it will actually suppress the inflammatory response. Okay, that's how it is working. So your corticosteroid is not actually healing that space. It is not disinfecting that canal. It is not acting on the bacteria. It is acting on the immune response of the patient. It's actually suppressing the inflammatory response, thereby the patient is not having pain. So that is how it acts, not by disinfection. So always antibiotic is the best option. So what we need is action against the bacteria, not against the inflammatory response. Yeah. So saline or distilled water. Yeah, we recommend actually according to the books. So whenever we do a study also, the final irrigation should be done with deionized water or distilled water. Okay, so that is the protocol. But in clinical practice, already we have too much to do. I don't have time to go and fetch distilled water. Okay, so that's why I don't use it as a end of my treatment protocol, but it is actually the ideal thing to use. So final irrigation should be done with deionized water or distilled water just before obturation. Yeah, okay.
Ma'am,
Irrigation.
how to avoid post BMP pain?
Yeah, post-obturation pain depends on many factors, doctor. The first factor is your files. Okay, so if you can find my YouTube channel, I have done a separate webinar over how files affect post-obturation pain. So whenever your files push debris into your apical region, okay, some of the files they actually move the debris towards the coronal region. Some of the files they will push the debris towards the apical region. Okay, the file cross section plays an important role here, and also your working length determination. So when you haven't properly determine the working length, and also your file cross section is also like triangular or something which pushes the debris into the apical region. In those cases what happened is that the debris is pushed into the apical region, so there will be a inflammatory response created by BMP. Okay, so because of which the patient will have post-obturation pain. So one thing what you can do is correct determination of working length. Okay, constricting your working space within the minor constriction. The second thing, you need to use a rectangular cross-sectional files which is of high cost. Okay, and regular irrigation. Okay, never once you have filed a canal, never skip and go to the next file. Irrigate, and then go to the next file. That way you can prevent debris extrusion into the apical space, and you won't have any post-op pain if you're going to follow the steps. Yeah, in hydrogen peroxide, no, doctor, don't use use only sodium hypo, or else you can use even devitalizer also. I don't recommend hydrogen peroxide. You can use devitalizer. If you think too much of bleeding is there, just keep a little bit of devitalizer on the canal, make the patient sit for 10 minutes, little bit of bleeding will stop. Then you can go about doing the procedure. Okay. And
Doctor, is
this.
Formocresol allowed? Formocresol.
Formocresol is not allowed to place for the entire week. Okay, so you do not give formocresol packing and send the patient home. You just keep it there to transiently stop the bleeding, and then you can go about after a little bit of bleeding has stopped, you will have a clear picture. Then you can go about doing pulp extirpation. Okay. So you should
Thank
not
you, doctor.
send the patient with formocresol. What happens is that when the formocresol reaches the periapical region, it is carcinogenic. Recently, they have about 10 years ago, they have found it. Before that, we were using it very generously. But right now, according to the recommendation, you don't send patient with formocresol home. That is, before we used to keep formocresol in the pulp chamber, give close dressing and send them home. Okay. And right now we don't do that. We can place formocresol for 10 to 15 minutes, arrest the bleeding, and then we can go about the procedure and remove the formocresol, and then we can send the patient home. Yeah, okay. Then abutment teeth needs RCT. Yes, doctor. In my practice, I don't take any risk. All my abutment teeth, I do RCT. Okay, I don't believe in vital tooth cutting. I don't know, some prosthodontists believe that. Maybe they are very confident over vital tooth cutting. But I'm not very confident over vital tooth cutting. I'm confident over endo, so I do RCT and I'd go about crown and bridge. So all my abutment teeth will be RC treated. Role of hydrogen peroxide. I don't use hydrogen peroxide and I don't recommend also, doctor. None of my mentors are recommending hydrogen peroxide as far as I know. Curved canals case. So, doctor, usually what I do is first thing you can go about using I start with canal patency with your Dentsply files. Okay, so you can use either Mani K file, okay, or you can use RT files, which is very flexible, rectangular cross-sectional hand files, recently launched by Mani. You can go about using Mani RT files, okay, create a canal patency. Then you can go for your pathfinder, your glide path files, and then you can start with your shaping files and your preparation files. Okay, so this is how I do. So you can use RT files. It is very good rectangular cross section, that is, it will not push any debris, and it's a very good hand files. So stop using, I have literally stopped using K files. Either I go for C files or C plus files, or your another one in your Dentsply. So only that you can use RT files, then your glide path, then your shaping files, and your finishing files. So this is the protocol which I follow. And then how to sterilize GP. So GP you can sterilize by placing it on 5% sodium hypo for 30 seconds, doctor. So sodium hypo can also be used to sterilize GP. So you just keep it on sodium hypo, then dry it, saline wash, and then dry it, and you can just obturate. And paper point in on over GP, directly permanent restoration. Okay, so what I usually follow is after obturation directly composite. If I'm using bioceramic sealer, it is quite easy because it sets a little bit. But if you're using zinc oxide eugenol or calcium hydroxide based sealer, it would be quite difficult, okay, to keep a permanent restoration on the same day. What you can do is, yeah, you can keep sterile cotton or sterile Teflon and place a temporary cement. Nothing wrong in it. Just make sure that it is completely sealed. Okay, and you immediately place permanent restoration the next day or in 2 or 3 days itself. Okay, how to manage hypo accident? You cannot do anything, doctor. You just need to observe. Okay, give painkillers, and you need to refer to the hospital. Okay, so you cannot do much. You can give painkillers, you can observe up to 2 weeks. Once necrosed, the tissues are very difficult to bring back. Okay, hypo accident is not very normal. It is a serious issue only because what happens is that the tissues get necrosed. it will turn purplish in color. So once it has happened, you need to wait for the repair to happen on itself. You cannot do much. You can just give palliative treatment, you can give painkillers. And if it is very serious, we need to refer to a surgeon or a medical doctor. Okay. So do you use devitalizing agent? Yeah, that's what devitalizing agent can be temporarily used for 10 to 15 minutes. It will arrest bleeding. Yes, you can use it, but don't pack it and send home. And can we use hypo in open apex case? Yes, you can use hypo, but not into the canals, only in the pulp chamber. Mild activation, no intrusion. So whenever you're not going to force hypo, as far as you don't force hypo into the periapical region, no problem will be there. You just need to have a very gentle motion. Okay, gentle motion, just light action
Ma'am,
on the
I
tip.
have one question. In some
Yeah, doctor.
cases, when in pulpitis cases, when the patient doesn't let us open all the orifices, like we have opened the chamber, relieve the pressure, but not able to clean all the pulp chamber. One of the canals is very, very hyperactive. In this case, ma'am, what dressing should we pack? Because we try to remove the pulp extirpation, but I was not able to do it. I could remove only the distal part and the lingual one, but the buccal
Yeah,
canal,
doctor. So I
he
will
just
come to
wouldn't
it.
let me open.
I
So,
will tell you one thing. So if you think
mm,
that you can place a devitalizing agent, it is going to backfire
mm,
in this case. Why? Because what
okay,
happens, you haven't done a proper de-roofing, right? On this point, what you
correct.
have mentioned is you haven't done proper de-roofing.
Ah,
So there is
mm,
some pulp tissue under that roof. Okay.
ah,
Now you have placed a devitalizing agent and you have sent the patient to home. So why that region alone is so hyperactive is because of the inflammation of the pulp. So more LA
correct.
you gave, more the inflammation gets, so the pain doesn't get relieved at all. It is literally like a hot tooth. So now what happens is that this devitalizing agent will in fact increase the inflammation. Okay. So
Okay.
next time when the patient
Devitalizing
comes
means
back, yeah.
formocresol is also
Yeah,
devitalizing.
formocresol will actually increase the inflammation because it
So
is
how
not
do
in
we go
direct
about it?
contact. Why? Because you haven't de-roofed in that region. This
Correct,
formocresol is not in direct contact in that region, right? So if this
correct.
formocresol is not in direct contact, it will actually inflame only. It will not kill it. Okay, so it will be in
Okay.
it will not be it will not be very effective. Okay, so what happens is that it will get more inflamed than before. So next time when you're going to attempt it, the patient will be more active. Okay, literally they won't let you touch. So it's always better if you are, I wouldn't recommend giving a formocresol pack, but if you're going to place a formocresol pack, make sure you have de-roofed completely and the entire pulp comes in contact with the formocresol. So that is a
Otherwise, in
very,
such
yeah, otherwise
otherwise in
it will
such
lead to
cases,
inflammation
no,
and it will
otherwise in
actually,
such cases, can we just leave a cotton pellet and pack it, or do a open dressing and leave him?
we can give intrapulpal, and we need to extirpate. That is the only solution in this case. What
Mm,
you can do is, whenever you have a hot tooth, we can do
mm,
three things, which I usually recommend. First thing, identify hot tooth. Okay, so whenever you have a pulp chamber below closed tooth, okay, or below restoration, this hot
correct.
tooth chances are high. Okay, so in
Mm,
these
mm,
cases, you don't open directly. You give anti-inflammatories for 3 days, especially
mm,
ibuprofen 600 mg twice daily.
okay.
Okay,
Mm,
for
mm,
3 days, you reduce the inflammation of the pulp, then you go for access cavity preparation. Okay, this is first thing you can do as a precaution. Second thing, what works well is your pulpal injection, intrapulpal injection works well, but it is very
mm,
uncomfortable to the patient. Okay, so only
mm,
you need to keep the syringe, you should not bend the syringe, you need to keep it straight. You have to keep inject the LA under pressure. Okay, so you should
mm,
prick the patient should feel the pain, and when you're injecting also, the patient should feel the pain. Okay, only then it is a successful pulpal injection. So it is very uncomfortable to the patient. It is always better to give ibuprofen rather than go for intrapulpal. Other than that, what you can do is articaine. So more than lignocaine, in these cases, when you're going to give LA with lignocaine, infiltrations work better. Okay, so you can go for articaine infiltrations. That anesthesia will work much better. So you can go about deroofing and everything. So these things you can follow for hot tooth.
Ma'am,
Rather
Artican can be given intrapulpal?
intrapulpal, yes, doctor, no problem at all. You can give it
Okay.
intrapulpal, but it is not necessary. Okay, so
Okay.
articaine is not necessary to be given in intrapulpal. If you have decided to give intrapulpal, lignocaine itself is enough. But it will be very uncomfortable for the patient. Only if you have made the patient uncomfortable, your intrapulpal is successful. Other than that, what you can do is mild spraying with your lignocaine spray. You can just spray it in that region and then you can give intrapulpal. A little bit, the patient will feel a little bit less pain, what I have noticed in my practice. So usually whenever I see a very closed pulp chamber, I go about giving medication rather than release the pressure. Okay, so I give
Okay.
ibuprofen 600 mg and then only I start the case to take the risk. And
And
also
ma'am, if
I
we,
give
for some
articaine.
reason, if we have to leave the, like, we cannot de-roof everything, then what is the best thing we should do?
Usually what my mentors used to tell me is that you need to remove at least the pulp from the pulp chamber. Okay. So
Okay.
even if you leave the pulp in the root canal, it's fine. Okay. But in the pulp chamber, you
In the
need to remove the
chamber.
pulp. So what you can do is, even if the patient feels painful, just take a spoon excavator and
Scoop the pulp
scoop the
out.
pulp out. Yeah, scoop the pulp out. Okay.
Mm.
So that the pulp tissue in the pulp chamber is removed. Okay. Don't worry about the
Okay.
root canal. Pulp chamber in the pulp in the chamber, if the pulp tissue is removed, you can go about keeping devitalizing agent also in our unavoidable situation. So make sure your chamber is clear and you have deroofed properly so that your radicular pulp comes in contact with this devitalizing agent. Okay.
Okay. Okay, got it, ma'am. Thank you.
Yeah. Then best intracanal medicament. TAP, doctor, in huge lesions, when you have weeping canals and all, you can go for TAP. For proceed curve canals. Curve canals, you start with ProGlide. You can start with RT files and then you can go about using, you can use finders also, definders. Definders are a little bit firm, okay? But at the same time, a little bit flexible. And your RT files are very flexible. So you can start with either RT files or definders. And then you can go for ProGlide or glide path files, GPF and Coltine. And then you can, after that, it becomes easier, whatever files you use. Other than that, what you can do is after glide path, you can go for 4%, 20, 4% 25, then 6% 20 and 6% 25. So you don't form any ledge in if you're going by this series. So you can start with a hand file, get the canal patency, then you can go for a glide path file, then you can go for 4% 20 and then 4% 25, then go for the 6% files and finish off with the 6% files. Which splits? Doctor, whenever there is apical split, you don't obturate it with GP. Okay, the apical splits are obturated with bioceramic sealer. One side it will be GP, another side it will be bioceramic sealer. Yeah, we should depend on the sealer only, doctor. Whenever there is apical split, we should depend on the sealer. Other than that, sometimes we can enlarge a little bit. Okay, but there will be loss of dentin. So it's always you need to use a bioceramic sealer. Bioceramic sealer is very strong. So in fact, when you obturate completely a canal with bioceramic sealer, the retreatment is very difficult. Okay, so if you are going to obturate the entire canal with bioceramic sealer, it is quite expensive. That's why we don't do it. In fact, if you are going to obturate an entire canal with bioceramic sealer, it's quite difficult to remove than GP. Okay, it literally bonds with the tooth. So you can depend on bioceramic sealer in those split cases. So you need to have a very good irrigation protocol. So you need to activate properly so that your sealer goes into that canal. That is very important. Sequence of filing in curved canal. So I have covered that. Sterilize paper points. I usually don't sterilize paper points and all. I sterilize only the GP and cotton. Yeah, you can sterilize it with autoclave, doctor. Cotton, like usually how we do for extractions and all, right? For extraction, we use sterile cotton, right? The same cotton can be used. Curved canal BMP. Yeah. So I have covered that, I guess. So you need to start with a DFinder or a RT file to get the canal patency. Then you follow it up with glide path files. You get glide path files in Dentsply Pro Glide files you get, or in Coltin you get GPF, and in Neo also you get Neo Glide, something like that, Oricam. So that is very economical and it's very good also. The glide path file of Oricam is also very good. And you next file would be my 24%. So 24% I love to use Genendo. Okay, so next file would be my 24% and 25% of Genendo, followed by my last finishing file would always be 26% and then 25.6%, depending on the size of the canal. So it's not like you just buy one file and you use the same file. Okay, I never buy assorted. I buy glide files from one. If I buy it from Oricam, I buy Genendo files 24% and 25.4% from Coltin, and I buy 26% and 25.6% from Dentsply. Okay, so it's always a mix of files. So you can use the same protocol. Okay, so in curved canals, you can start with glide path files, hand files, glide path files, and then you can go for 4% files, and then you can go to 6% files and finish it off. How
Ma'am,
to
for
do
drying
complete?
canal, ma'am,
Yes,
drying
doctor.
canal के लिए what should be the other solution except these GP points?
Doctor, I'm not getting you clearly.
Ma'am, for drying canal after irrigation, what will be the solvent? Except this
For
paper
dry
points.
canal, okay. After irrigation, what will be the solvent?
Yes, ma'am.
Doctor, for every canal, may it be dry or anything, dry canal after drying, after using chlorhexidine and saline, you dry the canal and you obturate, right, doctor?
Ma'am, actually, ma'am, I just want to know ki, is there some solvent for drying canal to proper flow for that sealers?
No, doctor, there is nothing like that. So after doing BMP, you need to use EDTA liquid to remove any debris or remove any smear layer off. Okay, so that step will remove debris, and then after that, you can go about using chlorhexidine to disinfect, then saline, and then dry the canal. The canal will be clean. Okay, so now when you're going to obturate, obviously the sealer will penetrate deeply. Okay, so no problem
Ma'am, I
will be there.
they just want to know, ma'am, how to flow these sealers in all the narrow canals. You know, how much
So
time needed for one canal for complete.
yeah, usually bioceramic sealers, they will come like a syringe system. You directly inject the sealer into the canal and then you place the GP. So literally it will flow. Okay. Or else if you're coating the GP with the sealer, you need to coat it minimum twice. So what I usually do is I will coat the GP, I will keep it inside the canal, I will do a little bit of pumping action, and then again I will coat the GP and again I will keep it in the canal and then obturate. So in this way there will be sufficient sealer, and I will always check before cutting my GP. So I will take an RVG and I will check whether the sealer has flown completely and whether there is any defects or not. Then I will cut the GP and I will do the obturation, doctor.
Ma'am, you don't take the sealant with the spreader?
No, doctor. Right now, what I'm doing is using bioceramic sealer. Okay, so I
Okay.
inject the sealer into the canal and just keep the GP. Okay, when you're using bioceramic sealer, you need not pump very deeply. You just need to pump it from the coronal. So that alone is enough. Yeah, sometimes I use Seal Apex also, care. So what I do is I use lentulospiral. Okay, so I will cover the sealer with lentulospiral and I will just use lentulospiral into the canal, so that will actually spread the sealer, right? Then I will coat my GP with the sealer and I will place it inside the canal. Is it clear, doctor? You
Ma'am,
can
with
use
with
lentulospiral.
AH plus we can use lentulospiral?
AH plus never use, doctor. Don't use. It's
Don't use
literally
AH
not at
plus.
all recommended. AH plus, all failure cases only. Don't use AH plus.
Then which
You
one
can
do you
use
recommend?
MTA Filapex. You can Safe Endo bioceramic sealer is very good, doctor. Safe Endo
Safe
bioceramic
Endo
sealer is
is
very
from
economical and it's very good also.
Safe
And
Endo
you
is
can
from which brand?
it's a brand actually. Safe Endo is a
Okay.
brand. It is the brand.
Okay.
Okay. Safe Endo, BioRoot RCS, I guess. Yeah. So bioceramic sealer is very good. And then golden standard is actually your I guess Septodent. BioRoot bioceramic sealer is the golden standard, but it is quite costly. Okay, it's around 5K or 6K. But your Safe Endo is economical only. It's around
Ma'am, when we
2.7K.
do retreatment with the bioceramics, we use a different this thing, no, not oil of orange. It doesn't like we use a different, what do you call it? Gatapacha dissolvent. If
If
we are
you're
using a
doing a retreatment,
bioceramic, yeah, retreatment.
if you're doing retreatment on a bioceramic case, right?
Yeah, yeah. What is the material that we use
We
to
can use
remove the
gutta percha
GP?
solvent itself, doctor, but we need to use rotary files, retreatment rotary files. Very good retreatment rotary files like your high flex remover can only remove. Okay. So you can use retreatment rotary files like high flex remover or your dense ply retreatment files. It's very firm. Your dense ply retreatment files are very firm. So initially you can start with dense ply retreatment files to remove the GP off. And then when you're reaching the apical region, you can switch to Coltine, this retreatment files, your high flex remover. High flex removers are very flexible. Okay. So you can remove bioceramic sealer. Okay. So when will you do a retreatment, doctor? So whenever the seal is not proper, right? So most of the time, even if we use bioceramic sealer, if there is a lesion, so usually with bioceramic sealer, the failure rate is literally very low. Okay. If there is a failure, even after using a bioceramic sealer, then for sure the obturation is not that much good. Okay. So you should be able to remove the GP very easily.
And one more thing I wanted to ask you, Dentsply retreatment files, what is the name or the number that we use? Like D files, right?
D1, yeah, D1, D2, D3 will be there, doctor. So D1 is
Okay.
literally like a orifice opener, and then you use
Hmm.
D2. D3 is
Hmm.
just like your F2 or F3. Okay, just a
So
finishing point.
D1, D2, we use it till the apical length or till the middle third?
No, it will just go till middle third. Your D3 will go till apical third.
Okay.
But
Mhm.
your D3 is not very flexible. Okay, so in curved
Yeah, so if
cases,
it's a curved, we should switch to
D3 is
Coltine.
not, I don't recommend D3. Okay, in curved
Correct,
and all,
correct.
I don't recommend D3. D3 can go till apex, but it is not that much flexible. Your high flex remover is quite flexible, or else you can switch to a normal file as well. So after removing
And
GP,
ma'am,
you
is
can
there
switch to
like
normal
a
files.
direction for using this? Should these files be used in a reverse
Yeah,
direction?
usually we will be doing watch winding, right? So here we will be
Yeah.
doing pecking action. So we will just peck,
What is that?
peck, like this, like this, like this. So are you
Okay,
scratching?
so not rotary, like it should be hand file.
It is rotary, but your motion will be like this. You just peck, peck, peck. Like,
Ah, okay,
okay.
okay. Mm-hmm.
Ma'am, one
Okay, ma'am.
question.
Thank you.
Yeah, yeah, doctor.
Yeah, when we use the rotary files, do we keep it 0.5 mm short of working length, or do we go to the 0 reading?
0.5 mm short, doctor. Always our working length should be 0.5 mm short. Why? Because we need that buffer, because our instruments, even though we keep it correctly at 19 mm, we always don't prepare till 19 mm, right? That is the reason why. So 0.5 mm, even if you don't prepare, our irrigants will take care of that. Okay. So you need to keep 0.5 mm shorter. So even in your apex locator also, you need to measure accordingly. So you will keep that, 0.5 mm shorter, and then only you will be doing it. So there will be settings, right? From the
Yeah.
apex 0.5 itself, you have to, that indicator will come. So always keep it 0.5 mm short.
No. My question is like we keep 0.5 mm short with the K files. So for the rotary files, do we have to go again 0.5 mm? That means 1 mm from the.
No, doctor, the same thing what working length you have in your hand files,
And file. All
same
right.
thing you
Okay.
can follow. Okay.
All right.
Yeah, same thing you can follow. Only thing is repeat your working length determination
Yeah,
after
with the
your
Excel.
glide path files.
Oh,
Okay. So that I
okay.
mentioned, right? So after glide path file, once again check your working length.
All
Okay.
right. All right.
Eugenol liquid for immediate pain relief and Hexigel for first canal location as disinfectant and pain relief. I haven't used doctor. Okay, eugenol is literally like it's a clove oil, right? So many of my patients they come and tell me I had pain, I bit a clove, my pain was relieved. Okay, so it's just a pain relief. It is not an antibiotic. Okay, so yeah, you can use anything for pain relief. That's not an issue. But it's better to use sodium hypo. That will also relieve the pain. If the patient is having pain because of the pulp, as soon as you use a sodium hypo, what happens is that the pulp is devitalized. Okay, so once the pulp is devitalized, then the patient is not going to have pain. Extra distal canal in lower molar. So you need to know something called laws of symmetry, doctor. Okay, so whenever the distal canal is at the center, okay, when you're going to draw a line through the long axis at the center of the tooth, if your distal canal falls on the line, then it's always a single distal canal. Okay, if it's on the either side of the line, that is side of the line, the say another orifice will be on at the same distance from that line. So that is how we do it. Like for example, let me just draw and show if you want. Yeah, so whenever you're going to draw, whenever you're going to have a distal canal, if this is the axis cavity, so you'll always have two canals, two mesial canals. So you draw a line through a long axis line through the center of the tooth in the mesiodistal direction. So whenever your canal falls over the line, it will be a single distal canal. So whenever your orifice is on the either side, on the side, you can find another orifice on this side. Okay, so when you know this law of symmetry, you will be able to find whether it is two distal canal or a single distal canal. Okay. So yeah. 5% files, that is your EDM, right? Or like your varying taper. Yeah, doctor, it does work well, but I don't think so. It's that much efficient in all cases. Like it lacks too much of. They tell you that it's a single file system, varying taper, but I don't find it like in curved canals and all. I cannot take risk putting a 5% file directly after a glide path file. So I usually don't go for single file systems, doctor. And especially in lesion cases, completely I don't use. So only in a vital tooth, I go about using this single file systems, 5% files. And aspirate cartridge syringe. So I haven't used that, doctor. Best method to use remove bioceramic sealer. Your Dentsply will remove. D1 and D2 will remove bioceramic sealer. That GP it will remove. So if you want to remove, if a canal is completely obturated with bioceramic sealer, no GP at all, then it can be removed only with ultrasound. Okay, so ultrasonic tips. You can use same this ED15D. You can use it and you can just trough through the bioceramic sealer to remove. Currently I use only bioceramic sealer and sometimes I do use calcium hydroxide based sealer as well. Okay, two-paste system like your Seal Apex and all. Because in all my clinics is not same. One of my clinic is it's economical one only. So I go about using Seal Apex two-paste system. So that how I dispense is by using lentulospiral. Okay, and coating the GP, one pumping action, then again coat the GP and then keep the GP and obturate. How much to prepare? Yeah, you can narrow canals, you can prepare up to 26%, doctor. Okay, minimum 26% in posteriors. Which matrix and retainers? Real matrix I use, doctor, for deep marginal elevations. when can we have same webinar next time? We have to ask your IADP. And then should we put cotton pellet in pulp chamber below temporary cement? Yes, you can do that, doctor, but make sure that the cotton pellet is sterile and the temporary cement has completely sealed the pulp chamber and sealed the tooth. And don't leave it for more days. Okay, so make sure you have changed it into permanent restoration within 3 days. Okay, and is it necessary to de-occlude tooth before RCT? Yes, yeah, but I don't do it. Okay, I don't do it because I always don't go for crown. Okay, I sometimes go for inlay only. So I literally don't cut unnecessary tooth structure. So why we do it is because the patient might have post-observation pain when they are biting. Okay, so if I'm using a very good file system, if I'm using a very good irrigation system, my debris will not get extruded periapically and the patient is not going to have post-observation pain, right? So there is no problem at all. There is no requirement for me to do occlusal reduction. So I just don't do occlusal reduction. So if you are doing all these things correctly, the patient is not going to have that much of post-observation pain. They might have post-observation pain for 1 or 2 days. That's all. And in every case, should we do LA hypersensitivity test? Um, it's not practical, doctor. Okay, according to the theory, yes, but when it comes to clinical practice, it is actually very difficult to follow the protocols sometimes. Yeah. Doctors, the questions, yeah, solution for post-obturation pain. Post-obturation pain, mostly if it is just because of BMP, like that is debris extrusion, then it should go off just by 1 week. So it will be maximum for 1 week. You can give aciclovir SP with ceratidopeptidase and you can give like painkillers for 3 days, like with SP. It will actually, the pain will reduce within 1 week if it is just because of BMP. But if you have obturated beyond, okay, that is going to irritate, or it is because of still the lesion is present, okay, or you have missed a canal or something like that, some mistakes you have done, then the post-obturation pain will not taper even after 2 weeks. Okay. So if you're having post-obturation pain even after 2 weeks, then you need to repeat your RCT. That would be my recommendation. Okay, so if the post-obturation pain after 1 week it is receding, like even after giving medications, it's getting all right, then it's just because of your BMP. Okay, so if it is not going off even after 2 weeks, it's better to repeat the RCT. How to do complete BMP in long root canals in lower molar till apex? Doctor, this you need to use the files according to it.
Ma'am, which are the files that you mentioned with the rectangular cross section?
Rectangular cross sections, you have your yeah, your EDM files are actually rectangular cross section. Then in your new endo also you have flex. Okay, so that is has rectangular cross section, and then you have your Dentsply also. Your Wave1 Gold are rectangular cross section, and ProTaper Gold is actually off center, not off center rectangular. It is a little bit of pentagonal shaped. Okay, so that also doesn't extrude debris a lot. So you can use your Dentsply ProTaper also. All these files are actually, you can check in the manufacturer, doctor, as far as I know, because I'm using these, but there are many files which have rectangular cross section. You just need to check the specifications. Orange
There
oil,
any
I don't know,
flexible
doctor.
or controlled memory files that have this rectangular cross section, flexible or controlled memory?
No, doctor. That is actually your this control memory depends on the heat treatment. Okay, so how much heat they are treating the file to. So if the heat treatment is only 400 degrees Celsius, it will turn into a blue file. Okay. And then if it is more 600 or 800 degrees Celsius, it will turn into a brown file or a deep golden file. And more heat treatment is done, it will turn into a gray file. So more you heat treat it, more flexible it becomes. Okay. So that is how your heat treatment controls your memory. Okay. But what controls this your cross section is the how the file is designed. Okay, so the design of the file. So when you cut the file, you find the cutting edges, right? So depending on that, you can see whether the debris will be moved upside or it will be pushed down. Single cone obturation is more successful when done with bioceramic sealer. Okay, and you should not do thermoplasticized obturation with bioceramic sealer. If you are going for down pack or anything, you need to use some other sealer. Okay, not the bioceramic sealer. Yeah. So when should discard? You can discard after 3 to 5 cases, doctor. That is my recommendation. After 3 to 5 cases, definitely discard the rotary files. If not, at least when it is veered off. Very large canals, you can find F3 and F4, F5 files in even Valdent also it is available online. So you can go for buying F4 and F5, which corresponds to 35 and 40 size apical enlargement, or you can use hand files. 90 to 140 hand files, K files, you can use hand files to prepare large canals. So as soon as I open my pulp chamber, the first thing what I do is orifice enlargement. Okay. And after that, I will be using K files, 10 size most probably, if it is a very like molars or anything. And if it is young patients, I go about using 15 size K file. Pro taper also, doctor, even I have used. Yeah, doctor.
Sorry, ma'am. Ma'am, have you used the new endo, not the flex file, but the S file?
Yes files, yeah. Yes files, they have more cutting efficiency. Okay. So if you want a very, like if it's a very calcified canal or something like that, when you want to cut through the canal, your S files are very good, but they do push debris. Okay. So your rectangular files, which I mentioned, that do not push the debris, right? They have very less cutting efficiency. Okay. So there is always pros and cons. So your S files, they push debris, but at the same time, they have very good cutting efficiency. Okay, but your off-center rectangular files, they don't have that much of cutting efficiency when compared to S. They do cut, but they don't, as compared to S files, they don't cut that much. But they don't push debris into the periapical region. So you need to decide according to the case. Do you require cutting efficiency or do you require not pushing the debris? Okay. Opening dress.
Ma'am, I'm
Open
asking
dressing.
actually because very recently only I used this new endo flex file that you're saying, but I was not able to pre-curve the file, the first one, the
And also you will
24%
face
file.
another one problem also. When you are finishing with flex files, your
Yes, ma'am.
GP will not fit till the apex, right?
Oh, okay. So
Why? Because it extends. Okay, the flex files actually it extends. It doesn't cut through the tooth. So what happens is that it is not at all that much flexible. So it doesn't reach till the
then
apex
why is it
properly.
called flex file then?
What, doctor?
Then why is it called flex file? I like by your name I
Yeah,
thought
it is
it was
called
flexible.
flex files. That's why my finishing file is always pro taper. Okay.
Got it.
That's why my finishing file is always pro taper. Why? Because that is good to finish with. Okay.
Ma'am,
So
which
I
is a
might start with Oricam, but I will end with Dentsply.
ma'am, but which is a file system which I can pre-curve with every file, at least the starting files. Because if
Starting
I don't get
glide path
pre-cut,
files, all the glide path files you can pre-curve, doctor. All
No,
the
but
glide path files.
24% and all those files, if I want to pre-curve, because I
So
don't
when
enjoy
you
endo,
pre-curve,
so I'm
doctor,
not
for
able to.
what situation you will pre-curve?
If it's a very posterior tooth, the access is slightly difficult, and I'm not able to visualize the canals like properly in the mouth mirror, and
Okay.
for those cases,
Rotary files are quite like whenever it's of 6% taper, it is quite difficult to
but at least the
pre-curve.
4% ones, so that I at least established a good pathway for my BMP, and
Your
then
flex
like
files you can pre-curve to an extent, doctor.
no, I was
It
not
will,
able to pre-curve, ma'am.
you
It
were
actually
not
broke
able
in my
to.
hand. No,
That
ma'am.
is the maximum I can tell. Try with Genendo if you want.
Janet.
Genendo, yeah, try with Genendo.
Okay.
Genendo
Okay.
will curve a little bit. Yeah.
Okay, ma'am.
So, but I find flex files can
Or
be
should I
pre-curved.
only use the control
That is the
memory
maximum you
one?
can expect because it's 4% or 6%, right? It will be a little bit stiff. You cannot curve it a lot. Okay.
But can we pre-curve the control memory ones, the Coltine ones?
Yeah, you can try with Genendo, or else you
Janet.
can go. You can try with Super Endo Blue also. You can try
Blue.
with that, and also you can try with this Coltine your control memory files. Yeah, Coltine control
Okay.
memory files also blue color only.
Are
You
there
can
any
try with that.
control memory files with NeoEndo?
Yeah, doctor, it is there, no?
Okay.
It is there
I'll
actually.
ask
Hybrid.
my vendor.
Yeah, it is called as hybrid, I guess. Hybrid files.
Thank you, ma'am.
Yeah, sure. Case of lower third molars, good rotary file system for extremely curved canal. Doctor, you can use EDM. You can use HyFlex EDM. HyFlex control memory files are very good. Okay, for extremely curved canal, extremely calcified canals, your EDM cuts through. Okay, so your EDM files are very good in calcified and curved canals. But initially, you have to start with your glide path and your 4% files, and final file should be your EDM. Okay. How much you charge for molar RCT? Doctor, it depends on my practice. Okay. In one of my practice, I charge only 3,500. In one of my practice, I charge 5,000. In one of my practice, I charge 10,000. Okay. It always depends on area. I will not tell it will depend on doctor. Sometimes it depends on area also. And also the type of practice. Okay. The type of practice, one of my practice is microscope oriented. So there I charge more. Yeah, encounter breakage of files. Which are the files which are breakage proof? Files which are breakage proof, any file will break, doctor. Okay, so it will break in situations, but repeated usage, you will have more chances of breakage. So literally, even your super endo can also break, even your protaper also can break. So it doesn't depend on the files, it depends on the usage, it depends on the cyclic fatigue and also the canal anatomy. So if you're using it in a curved canal, it will flex more. So whenever you're using in a curved canal or a calcified canal, try to use a new file. Okay, don't use old files. Open dressing in abscess cases. Yeah, weeping canal, you need to give open dressing for 1 or 2 days. Completely drain the canal and then you can go for intracanal medicament placement and you can do the go about other procedures. Yeah, doctor. What I do is I just do orifice enlargement. Before now, right now I know I'm that much experienced that I know where the orifices location are. So I'm not able to answer this question. So before, what I used to do when I didn't know whether it was because of like a pulp or anything, what I used to do is first place a little bit of devitalizer, arrest the bleeding, and then I used to go for doing all those things. But right now, what I do is I immediately start filing. Okay. When I have continuous bleeding, I start filing. Why? Because the bleeding is because of pulp. When I start filing, the pulp is going to get removed and the bleeding is going to taper. So I start filing in currently. Yeah, when should we use high speed and torque in endomotor? High speed should be used in your glide path files and less torque in your endomotor files. sorry, your like 6% and 20 or 6% 25 files, you should keep it in high torque. Okay. A good GP cutter. GP cutter is always noise cutter, doctor. I use my noise plier. You can always use that. I don't go for any specific GP cutters. It will be like noise forceps. Okay, you can find it NOYES, noise forceps. Crown or composite, which is best? Crown is the best. Composite can be best when you're using a very good composite. Okay, so there are composites like 1 syringe 5K. For example, your Voco Extra Fill, which I recommend, bulk fill material, and your Tetric Evoceram, not the Enceram, Tetric Evoceram or Power Fill, or your this Impress and all. So these composites even are better than your 3,000, 4,000 crowns. Okay, so the lab charges what we give for 800, what we get, right? That crown, Sebi, this this composite, which I'm telling, this Voco Extra Fill, are much better in strength. So if you are going to use a composite which is very good, then fine. If you are not going to use a very good composite, then it's always better to go with crown. I go about autoclave only, doctor. Pack the files and autoclave, not more than 2 to 3 cycles of autoclaving. So after 3 cycles of autoclaving, your file breakage chances will increase. Okay. What about open dressing in abscess? Yeah, doctor. So open dressing, you need to give whenever there is a weeping canal, evident pus discharge or swelling is there, you need to give open dressing after complete drainage happened. Like you can leave a minimum like 1 or 2 days, not more than 2 days. Just leave it open with just a cotton for 1 or 2 days so that complete drainage happens. Then you call back the patient, do a BMP, place the intracanal medicament, and send the patient for 1 week. So this is how I do. Yeah. So I think the questions are going on and going on. It's literally night, I guess. It's literally 10:50. I think it's time to wind up, doctors. Okay, so if any doubts, you can just ask me through the number. Okay, so in my screen. So you can just text my assistant. So she will be, so these are the courses which I provide in Madurai. We have a endodontic course and an advanced aesthetic course. So if you have any more doubts, which I was not able to cover right now, you can always send message in this number. So my assistant will forward me these questions and I will be able to answer you, doctors. Okay. So thank you, doctors. Thank you so much. I will just wind up. Doctor, are you available?
Yes.
Yes, doctor. So it had been a very long session, doctor. Sorry.
It's okay.
Yeah.
It's all right, ma'am.
Yeah. So let's just wind up, doctor. Thank you, doctor. Thank you.
Yeah. Okay. I'll end it with a note.
Yeah. Yeah.
Okay, so thank you so much, ma'am, for such a wonderful and informative session and your valuable insights on the common mistakes leading to RCT failures and the ways to avoid them were truly enlightening. We are sure that everyone attending today's session will leave with excellent clinical takeaways that can be implemented in daily practices for more predictable endodontic outcomes. And on behalf of IADPE, I would like to sincerely thank you for taking your valuable time to be a part of our Learn from the Master series and for sharing your knowledge and expertise with all of us. I would also like to thank all the doctors and participants for your patient listening, active participation, and continuous support towards our webinars. We hope today's session has boosted your confidence and enhanced your clinical understanding. Please do check out and follow Dr. Afshan Banu ma'am's Instagram page to appreciate her amazing clinical work and education content. And to know more about our upcoming webinars and workshops, kindly visit our website iadpe.org. You can also follow our Instagram, Facebook, and YouTube channels. And if you have missed any of our previous webinars, please do check them out on YouTube. And we would truly appreciate your support by subscribing to our channel as well. Once again, thank you all for joining us tonight and have a wonderful evening and a great night ahead. Good night, everyone.